مع الحرس الوطني او الحراس الشخصيين بعد هذه الحادثه. لا اذا كانت الروايه الاخرى روايه حكوميه.
Now it is recording. Yes, it is recording. Yes, it is recording.
Yes.
Okay.
Okay.
So our first topic, we will start with ectopic. This topic is very important. At least it comes as either EMQ or spot. You must have a question about ectopic. In last exam we had an EMQ about ectopic. So it is very important topic. You need to know how to diagnose. You need to know that there are a few numbers in here, like the cut numbers for diagnosis. You have to know these numbers by heart. Also, the treatment may come as single best answer. So everything in this guideline is very important. Of course, all of us know the definition of ectopic, which is any pregnancy implanted outside of the endometrial cavity. We have some risk factors like tubal damage following surgery or infection, smoking, IVF. IVF is usually associated with heterotopic. So when it comes in the exam, keep in mind that IVF may have intrauterine and extrauterine pregnancy at the same time. So this is important because, as I said, it comes in the question. He will give you that this patient has already done IVF. She came with severe abdominal pain. So you will be confused, either ovarian hyperstimulation or heterotopic. So you have to differentiate between these both. A third of cases has no identifiable risk factor. These are the most important numbers in this guideline. The incidence of ectopic is 11 per 1,000 pregnancies. 2 to 3% of women attending early pregnancy unit have ectopic pregnancy. The maternal mortality rate is 0.2 per 1,000. And the recurrence rate is 18.5%. All these numbers can come as a single best answer question. Every one of them, if you look at the recalls, you will see that every number of these had come previously at least once. So all these numbers are very important. This is referral. Referral is not for us. Referral usually is meant for GP because you know this guideline is a NICE guideline. So NICE is not intended for us alone. It is intended for any medical practitioner who may interact with this woman, a woman with ectopic pregnancy. So the referral is usually for GPs, but we have to at least have an idea about that when they will refer the case immediately. If she has a positive pregnancy test and one of or more of the following: pain and abdominal tenderness, pelvic tenderness, cervical motion tenderness. So any tenderness regarding our area of specialty, pain, abdomen, pelvis, or cervix. Any tenderness in these areas, suspect ectopic. This needs immediate referral. Refer at once. Don't delay. Refer, but according to the case or in front of you, if there is a bleeding and or other sign of or other symptom of early pregnancy, and they have also pain or pregnancy of 6 weeks gestation or more, and you cannot find it by ultrasound. Pregnancy of uncertain gestation, she don't know when were her lost. The second and third, this is mainly for diagnosis of pregnancy, to know where is the pregnancy, to know is it viable or no. this is mostly the second and third reasons are for this, just to diagnose pregnancy. He is not suspecting either intra or extra. He just want to know, is this a pregnancy? Where is this pregnancy? To know the location of the pregnancy. Okay, symptoms and signs. This is referral. We know that if a patient is hemodynamically unstable, GP cannot deal with it. He have to transfer it to us. And when there is a significant concern about the degree of the pain or bleeding, if she is in severe pain or she has horrible bleeding, he have to refer. He don't have the ability to deal with this, so he have to transfer her to us. So these cases are the one who will come to us, and these are the one who we will be dealing with. So she will come to the GP with one of these, and he will refer to us. Okay, and keep in mind that a typical presentation is very common with ectopic. Okay, in the guideline, he separates the symptoms and signs to common and reported. Common, this is a very important, this is a classical presentation. She will come with abdominal or pelvic pain. She will come with amenorrhea or missed period. She will have a vaginal bleeding with or without clots. One of these. This is a triad I remember from college. Always pain, bleeding, amenorrhea. These are the triad of any early pregnancy complication. Pain, bleeding, amenorrhea. The second is this is reported breast tenderness. This is a sign of pregnancy or symptom of pregnancy. Gastrointestinal symptoms. This is very important because sometimes it will be confused with irritable bowel. So you have to know that ectopic may come with gastrointestinal symptom. Dizziness, fainting, or syncope. This is according to the amount of bleeding. Shoulder tip pain, irritation of nerves, urinary symptom, pressure or irritation of the bladder or something, passage of tissues. Passage of tissue, we will know after this that there is changes in the endometrium. This is changes in the endometrium. If the pregnancy is failing either inside or outside the uterus, these changes will appear as tissues like menses, but now it will the endometrium will be thicker. There will be the residual changes inside the endometrium. This can appear as tissues. Rectal pressure or pain in defecation. This is either by the pressure of the sac, and this is not common. But the common is that irritation, this is rupture or this is disturbed ectopic and began to affect the rectum. Okay, the signs, we have 3 common signs also. 3 are tenderness, pelvic, adnexal, and abdominal tenderness. The reported sign are cervical motion tenderness, rebound tenderness or peritoneal sign, pallor, abdominal distension, enlarged uterus, tachycardia or hypotension, shock or collapse, or orthostatic hypotension. All of these are signs of like the same as symptoms. They are signs of complication or are signs of the effect of ectopic on other organs. So these are reported signs. Okay, so anyone dealing with women in reproductive age, he must have access to pregnancy test. Any woman coming with abdominal problem or pelvic problem, she must submit a pregnancy test to exclude pregnancy, because as we saw that ectopic can resemble any abdominal or pelvic problem. How to diagnose ectopic pregnancy? Ectopic pregnancy, previously ectopic was only tubal and ovarian. We didn't have all these types. Now we have 8 types of ectopic. The first type is tubal, the second is cervical, cesarean scar, interstitial, corneal, ovarian, abdominal, and heterotopic. All these are subtypes of ectopic according to where the ectopic is. How we diagnose? We diagnose either by ultrasound or biochemical investigation or both. In the next slides, we will be discussing each one of them and what is the preferred method for its ultrasound criteria, and what biochemical test, if needed, what we do and for what. Okay, so this. We have general rules for the testing. Biochemical investigation, we don't do progesterone any longer. Progesterone have no rule. Beta HCG is only for planning management, not for diagnosis. So we cannot diagnose. Back in the day, they would diagnose ectopic according to the level of beta HCG. This is not acceptable anymore. Any case can have ectopic with low and with high beta HCG. This is no rule for diagnosis. For women with decrease in serum HCG level less than 50% or increase less than 63%, she will have to come to the early pregnancy unit for assessment within 24 hours, because this is not either failing, this is in between failing and in between progressing. This is the gray line. So the gray line, she has to come again to be reassessed. This is, if you looked at the guideline, you will see this is a very condensed paragraph. I tried to simplify it for my brain to understand. So first, a patient comes to us complaining of any problem. We wanted to diagnose pregnancy. We will offer here beta HCG, and we will repeat it after 48 hours. We will have one of three results. Either she is the result increases by 63% or by more than 63%, or she will be decreasing by 50% or more, or she will be in between. If she is if the level is increasing by 63 or more, this is most likely intrauterine pregnancy, but we cannot rule out that she has ectopic. So we will do transvaginal ultrasound 7 to 14 days or earlier if beta HCG is less than 1,500 international unit per mil. This will appear as viable intrauterine or not viable. Viable intrauterine, she will continue with the antenatal care routine. No, not viable, so she will continue as abortion. Sorry, miscarriage, because we have to differentiate between miscarriage and abortion, and this we will say in the miscarriage portion of this topic. Okay, if she is decreasing by 50% or more, so we will have to repeat the pregnancy test after 14 days. 14 days, it is important, this number 14 and 7 to 14, this comes as questions, when to repeat the test. So we will have to repeat the pregnancy test after 14 days, after the second, not after the first, after the doubling test, the test we did after 48 hours, okay? So if her level is decreasing, this is unlikely to continue. This is a failing pregnancy. We will give her oral and written advice, and we will see the test if the test is positive or negative. If the test is positive, we will ask her to return for review within 24 hours. If it is positive, Negative, okay, no further action. This is failed pregnancy and disappeared. Okay, if she is in between, she have to be referred, like we said before, she have to be referred within 24 hours. Okay, diagnosis of intrauterine pregnancy. Transvaginal is the method of choice. We have to look for fetal pool and heartbeat. We have to consider transabdominal ultrasound scan for women with enlarged uterus or pelvic pathology, because transvaginal will not be as accurate as transabdominal. Okay. When performing ultrasound scan, sorry, someone's mic is on, please. Okay, let me see whose mic is on. I don't know. Okay, diagnosis of intrauterine pregnancy. As we said, first the choice, the diagnosis of a choice is transvaginal. Then, if transvaginal is not an option, or like if she have enlarged uterus due to mass or something, we will have to do transabdominal. Also, if she refused, some patient will refuse transvaginal, so we will have to do transabdominal, but we have to tell her that transabdominal is not as accurate as transvaginal. Okay. First, we will look for heartbeat. If heartbeat is visible, if not visible, but there is a fetal pool, we will measure the crown rump length. Okay, the measurements we will be discussing in the next slide. We don't use mean gestational sac if there is a fetal pool. If no fetal pool, okay, we can measure the gestational sac. We will last menstrual period alone is not an accurate yes, this is from NICE and from this one is from NICE, but this is a combination between the NICE guideline and the GTG. We have both guideline, NICE and GTG, so this presentation is mixed between the both. Okay, so don't use so as I said, last menstrual period is not an indicator for to see if the back in the day we would say if she is more than 6 weeks, you should see visible pulse and stuff like that. This is no longer applicable. We have to measure. The measurement is our indicator. Okay. So also this one was like the first one. First we will do ultrasound. We will look for heartbeat. We will, if we see heartbeat visible, okay, this is viable intrauterine pregnancy. Not visible heartbeat, we will be looking for a fetal pool. There is a fetal pool, okay, we will measure crown rump length, transabdominal or transvaginal. For transabdominal, it is a rule. Record your measurements and repeat the transabdominal after 14 days. Okay. Transvaginal, we have 7. If 7 or more millimeters, then we will see second opinion or repeat after 7 days. We cannot diagnose either failed pregnancy, miscarriage, or ectopic from the first time until unless we are 100% sure. To make sure, we have to have second opinion or to repeat the test after 7 days. This is important, very, very important. It comes too many times in the exam. Okay. So if it is 7 millimeter or more, we will either get second opinion or repeat after 7 days, and this is viable pregnancy. This is sorry, if 7 or more and no fetal pool and no visible pulse, no, there is something wrong. This pregnancy is not likely to continue. If it is less than 7 millimeter, we will have to repeat after 7 days. It will grow and will be 7 millimeter, and we will apply the same pathway again. We will do ultrasound, look for heartbeat, if not visible, look for fetal pool, and so on. Okay. If we cannot find fetal pool, we will have to measure gestational sac. All this is depending on that we saw an intrauterine sac. This is diagnosis of intrauterine pregnancy. We already said that this is not a pregnancy of unknown location. This is intrauterine pregnancy. So negative fetal pool, but there is a gestational sac. We will measure the gestational sac. We said transabdominal, we have to record our reading and repeat after 14 days. If transabdominal, the cut, transvaginal, the cut point is 25 millimeter or more. 25, this number we will have again and again and again. It's a very important number that will appear a lot of times in our study. So keep it in your mind, because 25 you will see after this is a cervical length, and it has a lot of meanings and with us. So if it is 25 or more, so this is something, there is something wrong. We should have a fetal pulse by 25. We must have fetal pool if the gestational sac is more than 25 or more. So we will have to seek another opinion or repeat after 7 days. Okay, if the transvaginal is less than 25, the same. We will repeat after 7 days. Maybe it will be big enough to record the next time. Sorry, this is no back. Okay, so if you saw this is the next slide is first one. You will see that in the NICE guideline he only talks about tubal ectopic, but all the other types are found in the GTG. So I tried to mix both. And in the GTG, he will give you first the diagnosis alone, and after you pass 3-4 pages, you will find the treatment. So I tried to combine them together. First, we will be talking about tubal ectopic. As I said, this is a mix between the NICE guideline and the GTG. Okay, so ultrasound criteria, as we said, transvaginal is the method of choice. Back in the day, laparoscope was the gold standard. It is not nowadays. Nowadays, the gold standard is transvaginal. Okay, because false negative laparoscopies were 3 to 4.5%. Okay. What is a NICE criteria? I wrote NICE criteria for diagnosis because this is different from the GTG criteria for diagnosis of tubal ectopic. Okay, so there are sure signs that indicate high probability or possible signs. Sure signs, we will see the mass, adnexal mass moving separately from the ovary that contain gestational sac, comprising of a gestational sac containing yolk sac, or gestational sac and fetal pool with or without heartbeat. So here we saw the pregnancy. We saw it in the adnex. This is sure. We are sure, 100% sure. This is tubal ectopic. High probability, we saw an adnexal mass moving separately of the ovary, but empty gestational sac. That is complex and inhomogeneous. So you will find a sac that's empty gestational sac, complex and inhomogeneous. This may be this may be assessed in the tube. It may be anything. Because we didn't see the fetal pool, we didn't see that gestational yolk sac. A yolk sac is a sign of healthy pregnancy, or a viable pregnancy, not healthy, a viable pregnancy. So no, we didn't find a yolk sac. We just find a gestational sac. It may not be a gestational sac. Possible, we found empty uterus and collection of fluid within the uterine cavity. Maybe it is too early it is a very early ectopic, a very early intrauterine. Maybe it is ectopic. We don't know. So this possible, but not don't exclude ectopic. Okay. Self-referral. A patient with a history of ectopic can self-refer herself to the early pregnancy center. If she has a concern, if we were concerned about ectopic, she can be self-referred. If you told her that maybe you have an ectopic pregnancy and she developed any major sign or symptom, okay, go by yourself to the early pregnancy, because this is a serious complication. We cannot afford to delay the patient. Okay. What findings can we find? These findings you can find in the GTG. Okay, please, someone have their mic open. It's making much noise. Who is it? I don't know where to get. I have to. Okay, I think it is stopped. Okay, thank you, whoever you were. Okay. Oh yes, I think it is from managing participants. Yes, I found it. Okay, all are muted. Yes. Okay. Now all are muted. Sorry. Let us continue. Okay, the findings you can find in the GTG. There is inhomogeneous or non-cystic adnexal mass. This is the most common finding. You will find it in around 50 to 60%. Empty extrauterine gestational sac. This will present in 20 to 40%. So the possible pregnancy, possible ectopic are 50 to 60%. The highly, who will you define initially as highly probable? They will be 20 to 40%. But the sure, they only 15 to 20% of the cases will be sure from the first or the initial assessment. So this is what you will find in the initial assessment. We said that probably 50 to 60% will be probable, 20 to 40 will be highly suggestive, and only 15 to 20% will be sure as ectopic. Okay, pseudosac and intradecidual and double decidual sacs. These you have to know just what are they. I haven't seen any question regarding them before, but keep them in your mind. Pseudosac is a collection of fluid that may be seen within the uterine cavity in up to 20%. Okay, pseudosac is is a sign of ectopic, but a small anechoic cystic structure inside the uterus is more likely to be early intrauterine pregnancies than to be a pseudosac. So it is not that it is not important. If you saw it, don't diagnose ectopic. It may be intrauterine pregnancy. So alone cannot be used in the diagnosis. Intradecidual and double decidual signs, these both are signs of intrauterine pregnancy. Intradecidual sign is a fluid collection with an echogenic rim located within a markedly thickened decidua on one side of the uterine cavity. Just, as I said, just try to imagine it, try to keep it in your mind, but it never came before. Double decidual sign is intrauterine fluid collection surrounded by two concentric echogenic rings. Okay, let's move to the next slide. Okay, sorry. I want to. Okay. So women with positive pregnancy test and intrauterine smooth-walled and echoic cystic structure, they have 0.02% probability of ectopic. So pseudosac alone cannot diagnose ectopic. Free fluid is often seen on ultrasound, but it can be seen also in intrauterine pregnancy, as you see in the next slide. Echogenic fluid has been reported in 28 to 56% of ectopic pregnancy. It may signify tubal rupture, but most commonly due to leakage of blood from the fimbrial end of the fallopian tube. So here, biochemical investigation, as we said, is not for diagnosis, it is for management mainly. Back, there was a common misconception that single low serum beta HCG less than 1,000. This means an ectopic pregnancy is unlikely. But this is false, because ectopic pregnancy can be found in less than this. And we will see again that the beta HCG is used to choose the method of treatment. Okay, the initial serum beta HCG level is a key prognostic indicator for the success of conservative management. So beta HCG, we will have to remeasure if we choose to treat her conservatively. Conservatively, like we will just wait and see. Okay, management. First, expectant. Expectant, we will not do anything. We will wait and see. This for pregnancy less than 6 weeks. They are bleeding but have no pain and no risk factor. Like previous, we said risk factors before previous ectopic, tubal damage or something. She have no risk factor. Success rate is between 57 and 100 according to the selection criteria. The success rate differs according to how you select your cases, how you select the best candidates for expectant management. Okay, decreasing serum beta HCG level is also a good predictor of success. So if you choose someone with a failing pregnancy before expectant management, you will get a good result. As I said, this is as a prognosis depend on how you select your cases. We will advise her, because this patient with expectant management, she will be managed at home. She will go back to her home. So we will advise her to return if the bleeding continue or pain develops. to repeat a urine pregnancy test after 7 to 10 days and return if it is positive. Negative pregnancy test means that the pregnancy has miscarried and she don't want any further follow-up. Okay, refer women who return with worsened symptom, and as I said, referral is for GPs. So if she is worse, she will come back to us. Okay, and if she came to a GP, he will have to refer her immediately or at least within 24 hours. The time is of essence in ectopic pregnancy. The sooner she gets to us, the better the prognosis. Okay, expectant management. We have, if you read the NICE guideline, they always use two terms, offer and consider. Offer means this is the treatment of a choice. Consider, this is he gave puts the decision in your hands. According to the case of the, according to your clinical knowledge, according to how you see the patient, you have to proceed. Okay, so offer of if she is clinically stable and pain-free, tubal ectopic measuring less than 35 millimeter, no visible heartbeat on transvaginal ultrasound, serum HCG level 1000 or less, able to return for follow-up. Okay, so able to return for follow-up, this is very important in any patient who will be managed at home. Any patient who will be managed, who you are considered for management at home, we have to know where she lives. If she is like 2 hours away from our center, no, she cannot be managed at home. We have to choose the nearest, someone who will be here within 15 minutes, 30 minutes, maximum 1 hour, a small trip. She will have to come for a small trip, not a long trip. Okay, so, and we will consider expectant management when she is also clinically stable. It is the same criteria. It change, the only difference is the serum beta HCG level. If the serum beta HCG level is between 1000 and 1500, we would consider her for expectant management if everything else is very good. But if any of the others is not good, okay, this will have to be. We will have to choose other treatment method. Repeat beta HCG level on days 2, 4, and 7. This is important, and this you will find questions about this, the frequency of repeating beta HCG. If HCG level drop by 15% or more, we will repeat weekly until a negative result is obtained. If it don't fall by 15% or stay the same or rise, we will have to she will have to come again, and we will have to review her again, and maybe consider another method of treatment. This patient is not a candidate for, or she is at risk of failure of expectant management. Okay. This is the advice. Look, advice is mainly for part 3, not for part 2, but you have to at least read it, because if you read it now, you when you come again to read it in part 3, you will have an idea what to expect. Okay, so advice, we have according to or based on limited evidence, there is no difference in the following things between expectant and medical management. There is the rate of ectopic pregnancy ending naturally, risk of tubal rupture, the need of additional treatment, but they might need to be admitted urgently if their condition deteriorates, and health status, depression, or anxiety scores. All of these, there is no difference in them between expectant and medical management. Okay? Okay, medical management. Medical management in ectopic means methotrexate. You have to know methotrexate. Methotrexate is your friend for ectopic pregnancy. So methotrexate, the dose is 50 milli per meter square. Sorry, cubic meter. This is cubic, not square. 50 milligram per cubic meter. Success rate, so it depends on the surface area, body surface area. Success rate 65 to 95%, 3 to 27% requiring a second dose. Prophylactic methotrexate, some may use prophylactic methotrexate when they are doing laparoscopic salpingotomy, because as we will see again, salpingotomy is associated with persistent trophoblast. So you may consider giving a prophylactic methotrexate dose. Methotrexate is equally successful to surgery in certain cases of tubal ectopic. Okay, when to offer? We will offer it to women who have no significant pain, unruptured tubal ectopic, adnexal mass less than 35 millimeter, no visible heartbeat. And this no visible heartbeat is very important. You cannot give methotrexate and a viable fetus. This is important because this comes as questions. You will get a scenario where the patient, when you see visible heartbeat, and you will get the choice of expectant, medical, or surgical. Here you will have to go for surgical. You cannot use methotrexate on heartbeat. Okay, serum beta HCG level more than 1,500. Don't have intrauterine pregnancy. This is not a heterotopic pregnancy, because heterotopic pregnancy, maybe the intrauterine pregnancy is viable. So methotrexate is poisonous to this fetus. So you don't have to do this. If there is an intrauterine pregnancy, better to do surgery. And she is able to return, and she has no sensitivity to methotrexate. If you are giving the drug, make sure that the patient don't have sensitivity for this drug. Okay, methotrexate. We cannot offer methotrexate from the first visit unless you are 100% sure. If this patient is a sure ectopic pregnancy. If not, you don't give from the first time. She will come again for the follow-up after 7 days to repeat the ultrasound. Give her in the second visit. Don't give in the first visit. Offer the choice of either methotrexate or surgical management. If the woman she has beta HCG level at least 1,500 and less than 5,000 international unit per liter, who are able to return. So the first, if she is more than 1,000, if she is less than 1,500, we will have to give. If she is more and less than 5,000, in this time, no, we will have to give her the choice either to do to have methotrexate or to do surgery. But to use methotrexate, she should have no significant pain, a rupture ectopic, smaller than 35 millimeter, and no intrauterine pregnancy. Okay. We will measure again serum beta HCG at days 4 and 7 after we give methotrexate. And the same will apply. If the beta HCG level is decreasing more than 15%, we will measure weekly until less than 15%. If the level is not decreasing, or we will have to repeat transvaginal ultrasound. We should exclude if maybe it was too early and now it has a fetal heart, and the presence of significant hemoperitonei. You can give a second dose first. You can first offer her a second dose of methotrexate before opting for surgery. Can we predict success? Yes, we can predict success. If the initial serum beta HCG level is low, we will have a good success rate. If the ultrasound appearance of ectopic, yolk sac, fetal pool, fetal cardiac activity, all these are indicators of failure. Pre-treatment changes. If the pre-treatment change, if it is increase up, if the beta HCG increase of up to 11 to 20% over 48 hours before administration of methotrexate, this associated with a higher risk, higher rate of success. This is not increasing very much. It is increasing a small amount. This is a good predictor for success. Decrease anal beta HCG level from day 1 to day 4 after methotrexate. If the serum beta HCG is decreasing, this is 88 to 100% success rate. If the serum beta HCG level is increasing, it is 42 to 62% chance of success. And if we are treating patient with methotrexate, we have to tell her keep away from alcohol and folate-containing vitamins. Surgical management. We will offer it if the patient is unable to return. This is a first line. If she is unable to return, and or have any of the following: ectopic pregnancy with significant pain, adnexal mass more than 35 millimeter, ectopic pregnancy with a fetal heart visible in ultrasound, serum beta HCG level more than 5,000. We will, of course, surgery, laparoscopy better than laparotomy, and salpingectomy better than salpingotomy. You have to keep those in mind. Laparoscopy is better than laparotomy, and salpingectomy is better than salpingotomy. Salpingectomy is better than salpingotomy, but we may go for salpingotomy if the contralateral or if the other tube is damaged or had anything that can compromise her chances of future pregnancy. Sorry. So salpingotomy, up to 1 in 5 women, she will need a further treatment either by methotrexate or repeated or salpingectomy. We will have to measure one serum beta HCG level at 7 days after surgery. Then once per week till negative results is obtained. Because as I said, salpingotomy is associated with persistent trophoblast. There will be we will not remove all the trophoblasts, so some will remain inside the tube. So we have to do a pregnancy test. And with salpingectomy, she will have to do only urine pregnancy test after 3 weeks. When she have fertility reducing factor, intrauterine pregnancy rates 75% with salpingotomy and 40% with salpingectomy. But subsequent intrauterine pregnancy were greater than 90% in both groups. In women without fertility reducing factor. So if she has fertility reducing factor with salpingotomy, her chances of getting pregnancy is more. So salpingotomy is a choice. As I said, persistent trophoblast, this is a problem for salpingotomy, and this occur in 3.9 to 11%, and there is no way to tell who will get, who will develop and who will not. We cannot predict who will get, who will have persistent trophoblast. Okay. But there is factors that increase the risk, like higher preoperative serum beta HCG, rapid preoperative rise in serum beta HCG, or larger tubal mass. As I said, there is no definite risk. We cannot know who will develop and who will not. Okay, the second is cervical pregnancy. This is less than 1% of all ectopic gestations. Ultrasound criteria: empty uterus, a barrel-shaped cervix, and gestational sac present below the level of internal os. Barrel-shaped cervix and the gestational sac being below the internal os, these two differentiate it from cesarean scar ectopic. You have to know this, because this is a differential diagnosis. These go for differential diagnosis. The absence of a sliding sign. While you apply the transvaginal probe, you use the probe to apply pressure. If this is a miscarriage, you will find that the gestational sac will slide, will move from its place, but this will not happen with ectopic because this is attached here. This is her implantation site. Okay, if you use the color Doppler, you will find the blood flow around the gestational sac. Biochemical investigation: single serum beta HCG carried out at the time of ultrasound diagnosis to decide the management option. Serum beta HCG greater than 10,000 is associated with decreased chance of successful methotrexate treatment. How we will manage? Many methods are described, like dilated DNC, systemic methotrexate, local injection either of methotrexate or potassium chloride. But all of these are associated with horrible bleeding. So we have to have measures to control the bleeding, like uterine artery ligation or uterine artery embolization. Conservative management: very early with accurate diagnosis can be managed conservatively. If the gestational age is less than 12 weeks, no fetal cardiac activity, and low serum beta HCG level, we can consider medical treatment, but and surgical treatment is life-threatening. As I said, all the methods have limitation, so choose what you are more comfortable with. This never came as a case before. If it came, it will be as diagnosis, not as management, because as you see, the management is versatile and everyone would choose what he's best at. So when he gives you the choice to choose what you are better at, maybe mostly this will not come as a question. Okay, cesarean scar pregnancy. This is very, very important because it is associated with uterine rupture. It can be, look here, the implantation is in the myometrial defect at the site of the previous uterine scar. So it affects 1 in 2,000. And these pregnancy may be ongoing, potentially viable pregnancy or miscarriage within the scope. 13% firstly were misdiagnosed as intrauterine or cervical pregnancies. Natural history, how it's developed, no one knows. It has two different types. Now we have a pregnancy that is implanted on the scar. This pregnancy is either it will continue to protrude inside the uterus or outside the uterus. These are the two types. Either it will, with progression, it will grow inside the uterus, or it will grow abdominally. Okay. If you if suspected if suspected cesarean scar, if suspected cesarean scar, ectopic, okay, you will have to be 100% sure. Ultrasound is the key. MRI, it will not give you more details than ultrasound. Ultrasound, you will find empty uterine cavity, gestational sac, or solid mass of trophoblast located anteriorly at the level of internal os. Here, at the level of the internal os. That's why I told you to keep this in mind. Thin or absent layer of myometrium between the gestational sac and the bladder, evidence of prominent trophoblast or placental circulation on Doppler, empty endocervical canal. The cervix is no longer barrel-shaped. Biochemical investigation, beta HCG, this is a baseline. It doesn't help the diagnosis. It is only for management, as we said. Management. You have to counsel the patient that if this pregnancy continue and there is a good chance that this will proceed to uterine rupture, and this will have a severe maternal and morbidity and mortality. Both medical or surgical intervention with or without additional hemostatic measure can be considered. There is insufficient evidence to recommend any one specific intervention over the other. So choose what you are most comfortable with. The complication, emergency hysterectomy due to hemorrhage or morbidly adherent placenta, intra-abdominal rupture and severe vaginal hemorrhage, and they have 6 maternal deaths recorded due to hemorrhage. So here, hemorrhage and emergency hysterectomy are the main complications. Expectant management, if the small non-viable scar pregnancy, okay, we can consider. And also we can consider it if the pregnancy is growing inside the uterine cavity, but we will have to counsel her that she has a higher risk of hemorrhage and morbidly adherent placenta. Okay, and some patient, if she is trying to conceive for a long time, she would, and this is her first pregnancy or something like that, or she have a very low chance of getting pregnant, she will decline termination. And some patient will decline termination due to religious beliefs. So whatever the reason for her declining termination, you will have to use expectant management. Medical management, methotrexate, or we can inject intramuscular or systemic. We can inject also inside the gestational sac. The disadvantage is that we didn't remove the trophoblast. The trophoblast is still there. So there is a high risk of hemorrhage, and this while the retained placental there is a risk of hemorrhage while this retained placenta is degenerating. Okay, surgical management. either evacuation of the pregnancy, suction or hysteroscopic resection, or excision of the pregnancy. Suction evacuation, this is the most frequently described procedure. They do it combined with cervical circulage, Foley catheter insertion, or uterine artery embolization for additional hemostatic measures. Excisional techniques have, if you opt for excisional technique, you will have the advantage of removing the old scar and making a new one and repairing the defect. Okay, this decreases the risk in the future pregnancies. If it is second trimester ongoing pregnancy, this is a challenging because it have a higher risk for maternal morbidity, hysterectomy, whichever approach is taken. Okay. Interstitial pregnancy. This is a pregnancy implanted in the interstitial part of the fallopian tube. It affects 1% to 6.3%. So 1 to 6.3 of ectopic pregnancies will be interstitial. The ultrasound criteria, also empty uterus, product of conception located laterally in the interstitial part of the tube, surrounded by less than 5 millimeters of myometrium in all imaging planes. Interstitial line sign, it has a sensitivity of 80%, specificity of 98%. This is an thin echogenic line extending from the center of uterine cavity to the periphery of the interstitial sac. You will have to you can see this if you are more experienced in ultrasound. If the 2D ultrasound is not didn't give you a sure diagnosis, you can use a 3D ultrasound if available. Okay. MRI, also here MRI has a choice. You will see a gestational sac in the lateral of the corona, surrounded by myometrium, and the presence of intact junctional zone between the uterine cavity and the gestational sac-like structure. Also, all these supports the diagnosis. Biochemical, as we said, single beta HCG levels that can be repeated after 48 hours. Management, a non-surgical management if the patient is stable. Expectant, only suitable for women with low or significantly falling beta HCG level, because this part is very narrow. If this patient has any wrong any additional risk, it will rupture and you will face a ruptured or disturbed ectopic. Methotrexate is effective, but there is insufficient evidence to recommend. Surgical management by laparoscopic coronary resection or salpingotomy, this is an effective option. Okay, electrocauterization. Look, here he is describing how he can manage the bleeding. They used in one of the studies, they used the phosphorus diluted in 1,000 milli of normal saline, and they injected 150 to 250 milli of this diluted solution into the uterus. Okay, this will this to decrease the bleeding. Okay, all this portion is just a technique to decrease the bleeding. You can find it in the guideline. It is not. It is important for you for your practice, but never came in the exam. Coronal pregnancy. Coronal pregnancy, this is pregnancy in one horn of a bicornuate uterus, or on one lateral half of bifid uterus. Okay, incidence is 1 in 76,000 pregnancy. Ultrasound criteria, we will find single interstitial portion of fallopian tube in the main uterine body, and gestational sac or products of conception, mobile and separate from the uterus and completely surrounded by myometrium. Vascular pedicle adjoining the gestational sac to the unicornate uterus. Also, biochemical investigations, single serum beta HCG level and repeated after 48 hours. Management, excision. This is the management of a choice. Excise the rudimentary horn, either laparoscopy or laparotomy. Of course, laparoscopy is better, but you have to pay attention because back in the day they said that anomalies don't come alone. If you find one anomaly, you will have another. So make sure that there is no anomaly in the urinary tract while you are excising the corn. Okay, ovarian pregnancy. We have to differentiate from corpus luteal cyst, from tubal ectopic stuck to the ovary, from second corpus luteum, from ovarian germ cell tumor or other ovarian pathology. Ultrasound criteria, they haven't, there is no agreed, so no one, no specific criteria, but suggestive criteria like wide echogenic ring with internal anechoic area on the ovary, not possible to separate the cyst from the ovary. The corpus luteum should be identified separately. Color Doppler may aid detection of a fetal heart pulsation within the ovary. Complex echogenic adnexal mass with a free fluid in the Douglas pouch can represent rupture ovarian ectopic. Biochemical investigation, single beta HCG repeated after 48 hours. Management, definitive surgical management is the preferred. If laparoscopy is required to make a diagnosis. Systemic methotrexate can also be used when the risk of surgery is high, or the postoperatively if there is a persistent residual trophoblast or persistently elevated beta HCG. Minimal access surgery, this is laparoscopy. So laparoscopy is now is the treatment of the choice. Removal, we will remove either by inoculation or wedge resection. Inoculation, we will use blunt from to minimize the ovarian damage to the okay, and we have hemostasis can be achieved by electrocautery or suturing. Okay, oophorectomy occasionally required when there is coexisting ipsilateral ovarian pathology or excessive bleeding. If you cannot control the bleeding by just wedge resection or inoculation, remove the uterus, the ovary, sorry. If the ovary has another pathology, remove the ovary. So you will, this is open and see. The management of ovarian pregnancy by surgery is open and see. Abdominal pregnancy, ultrasound criteria, absence of an intrauterine gestational sac, absence of both evident diluted tube or complex adnexal mass, gestational cavity surrounded by loops of bowel separate from them by peritoneum, wide mobility similar to fluctuation in the sac, particularly evidence with pressure of the transvaginal probe. If you apply pressure, it will move like this. MRI here is useful because we want to know where is this pregnancy is attached. It may be attached to a major blood vessel. It may be attached to a wide part of intestinal lobes. It might only be attached to the omentum. We don't know. So it might be attached to the bladder. We have to know the exact attachment of this pregnancy so we can know how when we enter for operation we know what we are going to do. So this is to plan management. Okay, all this is this part is saying the same as I said. Biochemical investigation, high in so we can use a high index of suspicion, elevated based on elevated serum beta HCG and the ultrasound findings. Okay, early abdominal pregnancy is usually diagnosed at laparoscopy during investigation for persistently elevated serum beta HCG level. Management: surgery. It is the management of choice. Laparoscopic removal is an option. Systemic methotrexate and feticide or selective arterial embolization if it is attached to major blood vessel or some vital organ. We have to do this. Advanced abdominal pregnancy, these are associated with significant maternal and fetal morbidity and mortality, and once diagnosed, laparotomy. Okay. The surgical approach should be planned to avoid incision of the placenta. The placenta may be left in situ, and if it is attached to a major blood vessel or vital structure, and spontaneous resorption awaited but is associated with significant morbidity, like ileus, bowel obstruction, fistula, hemorrhage, peritonitis. But mortality rate is lower if it is left in situ than if it is removed. Heterotopics. Heterotopic pregnancy means an intrauterine coexisting with ectopic pregnancy. Heterotopic, it can be considered in all women presenting after IVF, as we said, with intrauterine pregnancy with complaining of persistent pelvic pain, in those women with persistently elevated beta HCG level following miscarriage or termination of pregnancy. Biochemical investigation, serum beta HCG here is of a limited value because we already have intrauterine pregnancy. Higher than expected level is may be suspicious of heterotopic gestation, although the presence of complete or partial moon must be considered. The management, we should keep the intrauterine pregnancy in our mind. Any method we are using, we should consider the intrauterine pregnancy first. So methotrexate only if both are non-viable. If not, the intrauterine and the ectopic are non-viable. Local injection of potassium chloride or hyperosmolar glucose with aspiration of the sac content. This is an option for a stable woman. Surgical removal. This is a method of choice for hemodynamically unstable and also an option for hemodynamically stable. Expectant if where the ultrasound finding are of non-viable pregnancy. If the heterotopic is non-viable, so we can use expectant management. Ultrasound follow-up. This is a necessity to ensure the resolution of the ectopic pregnancy because we cannot use beta HCG as indicator. Expectant management of interstitial heterotopic pregnancy in a symptom-free woman with ultrasound evidence that the interstitial pregnancy was not ongoing has been described. Also, expectant of an... Okay. So we can use expectant management if the intrauterine and extrauterine is failing, or at least the extrauterine is failing. We must do ultrasound follow-up, because we cannot rely on beta HCG for follow-up. Anti-D prophylaxis, the dose is 250 international unit. You must know the doses of anti-D. There's a separate guideline for anti-D. You have to know all the doses of anti-D, because anti-D is very important, and comes almost every exam. You will find a question about anti-D. Okay, so 250 should be given to all Rh negative who have surgical procedure to manage ectopic pregnancy or miscarriage, or where bleeding is repeated, heavy, or associated with abdominal pain. Kleehauer test below 12 weeks of gestation has no rule, so don't use it. Long-term fertility prospect following ectopic pregnancy. This also for part 3 mainly, in the absence of history of subfertility or tubal pathology, no evidence there is increased rate of infertility, or no difference in the rate of fertility. There is the risk of future tubal pregnancy or tubal patency. There is no difference. We said this before. Women with a previous history of subfertility should be advised that the treatment of their tubal ectopic with expectant or medical management have the same outcome. Women receiving methotrexate should be told that it has no effect on the ovarian reserve. When using uterine artery embolization or systemic methotrexate for non-tubal pregnancy, live birth has been reported in subsequent pregnancy. If undergoing laparoscopic management of ovarian pregnancy, they have a good future fertility prospects. Okay, support and counseling also for part 3. We should give muscle relaxant. We should give muscle relaxant training for these women, especially who's taking methotrexate. It is recommended that women treated with methotrexate wait at least 3 months before trying to conceive again. And this is an important, and this one came before this, that methotrexate, any woman who taking methotrexate for any reason, she has to wait at least 3 months before trying to conceive again. And this is the end of ectopic. Okay, now we have either to solve on the ectopic question related to ectopic, or continue and finish all the other part and then go back here. So what do you think?
Solve ectopic. Yes, inshallah.
Okay, I'll just read the questions. Ectopic is way back. Okay. Okay, can you see the slide?
Yes.
Okay. This is the first question. So if you want to answer, please raise your hand. You can raise the hand in the... Okay. Who will participate? Okay, I'll say, and you can either open your mic and say the answer, or you can write the answer. 26 years old woman has had a laparoscopic salpingotomy for an ectopic pregnancy. She inquired about the future risk of another ectopic and what is the risk of having a subsequent ectopic following salpingotomy. Okay, Dr. Hussam?
Maybe 20% D.
D. Okay. Let us see. No, the answer is B, 8%. Okay. This question is from Andrew Siege. You will find it in the sector in the early pregnancy complication. You know, it is in the last pages of the book. Okay, what is the diagnosis of a choice for tubal ectopic? Dr. Sarah?
Transvaginal ultrasound.
Yes, transvaginal is the treatment, is the diagnosis of a choice. Okay. You can continue, or someone else want to share? Okay. What proportion of ectopic pregnancy occur in the interstitial portion of the fallopian tube?
Okay, sorry.
A
1 to 6. Yes, it is 1 to 6. Okay. A woman attends early pregnancy unit having experienced some discomfort and vaginal bleeding in early pregnancy. It is 6 weeks since her last menstrual period. She is actively trying to conceive. A transvaginal ultrasound scan is performed, but there is no evidence of intrauterine gestational sac. Serum beta HCG level is 1,200. Beta HCG is repeated after 48 hours and is 950. What is the most appropriate management? Diagnostic laparoscopy, discharge, medical therapy, perform urinary pregnancy test, or repeat further beta HCG in 48 hours.
D.
A urinary pregnancy test. Okay, this is a failing pregnancy. Okay, so in failing pregnancy, we have we will reassure her, go to your home. This pregnancy is most likely it will not continue, and we will use a pregnancy test after 2 to 3 weeks to ensure that it is already gone. Okay. No, this is a miscarriage. And no, the rest, I think all the rest are miscarriage. Yes, wait, maybe no, all are miscarriage. Okay, we will now head to miscarriage. Okay, I'll just have to a minute. Miscarriage. Okay. Miscarriage is very easy. And every time you start studying, you have in the previous exam, every time we had to study, we start from here. So I think most of you who miscarriage is this one. Yes. Okay. Most of you who studied for the previous exam or who attended previous exam must have read this before. So first important number here is that 20%, this is the pregnancy, sorry, the miscarriage rate is 20%. It accounts for 50,000 admissions in the UK. 20%, this is very, very important. This is very, very important number. It comes a lot. These are definitions like early pregnancy, it is a pregnancy in the first trimester. These you can find in the NICE guideline. Expectant management is management approach when you wait and see what is with no additional medication or treatment. You just wait and see. Pregnancy of unknown location. This is a woman who have positive pregnancy test, but by ultrasound you cannot find a pregnancy. Okay. Diagnosis of intrauterine pregnancy. This we viable intrauterine pregnancy. This we already discussed in the ectopic portion of this lecture. The diagnosis of miscarriage is using one ultrasound scan cannot be 100% accurate, and another scan should be done to confirm. When diagnosing complete miscarriage, keep in mind if you have not done previous scan and intrauterine pregnancy was not confirmed, keep in mind that this may be ectopic. Okay, miscarriage. We have types of miscarriage, and the management will be according to the type. Okay, back we had threatened, missed, complete, and incomplete. Here he will not discuss all in detail, just enumerate some. Threatened miscarriage, we have to advise the woman with vaginal bleeding and confirmed intrauterine pregnancy that this is with a fetal heartbeat, that if her bleeding gets worse or persists beyond 14 days, she should return for further assessment. If the bleeding stops, she should start or continue routine antenatal care. Okay, expectant management. Use expectant management for 7 to 14 days, and this is important. We use it for 7 to 14 days as first line management. Explore other options. If the woman is at increased risk of hemorrhage, she has previous adverse effects or traumatic experience associated with pregnancy, she is at increased risk from the effect of hemorrhage, like she has a coagulopathy or unable to have blood transfusion. For those who are not able to have blood transfusion, like Jehovah's Witness. Jehovah's Witness believes that if a blood transfusion, if you transfuse the blood to them, that their souls will be damned and they cannot go to heaven. So they refuse blood. They accept some sort of blood products, but not whole blood. So these cases, you have to make sure that you keep this in mind, and you cannot manage them expectantly, because if it take any wrong turn, you will have a horrible consequence. There is evidence, or if there is evidence of infection. Okay, we will offer medical management with a confirmed diagnosis of miscarriage if expectant management is not acceptable to the woman, or if she has any of the above mentioned reasons. If the resolution of bleeding and pain indicates that the miscarriage has completed during 7 to 14 days, we have to advise the woman to take a pregnancy test, urine pregnancy test, after 3 weeks, and to return for individualized care if it is possible. We should ever offer a repeat scan if after the period of expectant management, 7 to 14 days, the pain and the bleeding has not started or are persistent and or increasing. Okay. We should review patients who opt for expectant management after a 14 days from the first follow-up. Medical management, mifepristone cannot be used for missed or incomplete miscarriage. As you see, the guideline, it jumps from one point to another, as I told you before. He first tell you about the threatened miscarriage, and then he will jump totally to a different part. So here he is talking about all the types. For missed and incomplete miscarriage, we should offer we should not offer mifepristone, but we should offer misoprostol, vaginal misoprostol. If the woman refuses vaginal, we can use oral as a substitute. For women with missed miscarriage, single dose of 800 micrograms of misoprostol can be used. If the bleeding has not started after 24 hours, she should contact the healthcare professional to determine. She should contact us, and we will tell her to come again to reassess her. Okay. If she has incomplete miscarriage, single dose 600 micrograms of misoprostol. So if it is you can, here you will see that missed miscarriage has a dose and incomplete miscarriage has a dose, but you can combine here. They said that we can use the same dose for both. So for incomplete, it is 600, but you can use the 800 just to remember the doses. They said you can use this because they want to make it easy for us to remember the doses. Offer all women who opt for medical management, pain relief and antiemetics. Okay, the potential side effects of treatment is pain, diarrhea, and vomiting. So we have to give her pain relief measurements and antiemetics. Urine pregnancy test after 3 weeks of medical management, unless they experience worsened symptoms. If such, tell her to come early, to come at once to reevaluate her status. If the urine pregnancy test is positive, also we will tell her to come to make sure that this is not molar or ectopic pregnancy. Surgical management, we can offer women surgical management, and we have to offer her either manual vacuum aspiration or surgical management in theater under general anesthesia. So we have outpatient procedure and inpatient procedure. She has to choose between them. We also have to provide her with oral and written information about everything, about the procedure, about the risk, about the outcome, everything. We have to give oral and written information. Anti-D. Here, anti-D has a big portion, not like in the ectopic. Anti-D, the same dose as in ectopic, 250. We should not offer anti-D if she is receiving only medical treatment for ectopic or miscarriage, or she have a threatened miscarriage, she have a complete miscarriage, or she have a pregnancy of unknown location. Any one of these, we don't have to give her anti-D. We should offer anti-D if she has a surgical procedure to manage either ectopic or miscarriage. This part is the lower part is repeat. Sorry. So as I said, the dose is 250. we should not give her if she is treated medically, if she has threatened miscarriage, complete miscarriage, or pregnancy of unknown location, she should not take anti-D. And the Kelly-Howard test, as we said in the ectopic, is no rule here. Recurrent miscarriage. The first portion, this part is from the NICE guidelines. This part is from the GTG. Okay. What's the meaning of miscarriage? Miscarriage is spontaneous loss of pregnancy before the fetus reaches viability. This is different from abortion. Back when I remember when I was in the college, they used to say abortion. All miscarriage and all either induced or spontaneous, they were called abortion. No, now only abortion, only the medically induced medically induced abortion. But if miscarriage, if it's spontaneous, it is miscarriage. If you induce it, iatrogenic induced, this is abortion. Okay, all pregnancy losses from the time of conception until 24 weeks of gestation. All these are miscarriage. 1 to 2% of second trimester pregnancies miscarry before 24 weeks of gestation. This number is important. It came before in the exam. Recurrent miscarriage, more than 3 consecutive pregnancy losses. Also, this part I want to tell you about. Last year, or last July. In last July, we used to study another guideline for this abortion, for miscarriage, and it was, I think, PASH, or I don't remember exactly what, but they used to define recurrent miscarriage as 2 or more. But according to GTG, it is 3 or more. So this is important that it is 3 or more consecutive pregnancy losses. It affects only 1% of couples trying to conceive. We have 7 risk factors. I summarized them here, and we will talk about each one of them except the immune factor. Epidemiological factor, antiphospholipid syndrome, genetic factor, anatomical, endocrine, immune, and inherited thrombophilia. First is epidemiologic factor. Epidemiologic factors, okay. The risk of miscarriage is highest among couples where the woman is 35 or more and the man is 40 or more. This part, very, very important. Age-related risk. You will have, look, every time we jump 5 years. So from, except from 12 to 19, okay? So from 20 to 24, 25 to 29, 30 to 34, 35 to 39, and 40 to 45, and more than 40. The number 13, 11, 12, sorry, 13, 11, 12, 15, 25, 51, 93. Look, try to remember it the way you like, but you have to know that every age group has a specific relative risk for recurrent miscarriage. So you must know this. This one comes a lot as well in the exam. Okay. The second part in the epidemiologic factors is the number of previous miscarriage. The risk of further miscarriage increased after each successive pregnancy loss, reaching approximately 40% after 3 consecutive pregnancy losses, and 40%, this also is a question. And the prognosis worsened with increased maternal age. So with increasing maternal age and increasing the number of miscarriage, sorry, both are increased. both increase the risk of further miscarriage. Previous live birth, this does not preclude women from developing recurrent miscarriage. She may have one or two live births, but she still undergo repeated miscarriage. Environmental risks like maternal cigarette smoking and caffeine consumption both increase the risk of spontaneous miscarriage. Heavy alcohol consumption, toxic to the embryo and the fetus. Even moderate consumption of 5 or more units per week. I think you can find a visual. After we finish, I will show you this. There's a visual demonstration of how much is a unit of alcohol in each different, like it will differ from beer to wine to different types of alcohol beverages. It will differ. Working or using video display terminals does not increase the risk of miscarriage. Anesthetic gases, this is there's not enough evidence to support this. Obesity has an effect on sporadic and recurrent miscarriage. So this is the environmental risk, and you can find, if you I think most of you tried to or already studied this week's schedule. You will have that, you will know that these are already in the guidelines for decrease for subfertility. So all these affect the fertility of the couples. Antiphospholipid. It is very important because it is the most important treatable cause of recurrent miscarriage. We have antiphospholipid antibodies, which are lupus anticoagulant, anticardiolipin antibody, anti-beta-2 glycoprotein 1 antibodies. These three are the antiphospholipid antibodies. You will find in the question box, but not in the. I don't think it came before in exam. But you will find this in previous box, in a question box, that he will enumerate and put the names of the tests next to each other, and he will substitute or change one name like this. So you have to memorize it if you are going to solve question box. And adverse pregnancy. This the antiphospholipid is an association between these antibodies and the adverse and the pregnancy outcome and vascular thrombus. The adverse pregnancy outcome: 3 or more consecutive miscarriage before 10 weeks. 1 or more morphologically normal fetal loss after 10 weeks, and 1 or more preterm birth before 34 weeks of gestation due to placental disease. All these are adverse effects of antiphospholipid. The mechanism of action of antiphospholipid syndrome: it inhibits the trophoblast function and differentiation, activation of complement pathway at the maternal fetal interface, resulting in local inflammatory response. In later pregnancy, thrombosis of the uteroplacental vasculature in vitro studies have shown that the effect is reversed by heparin. That's why we treat it with heparin and aspirin. Incidence, very important, 15% of recurrent miscarriage. Prevalence of in low risk is 2%, only 2%. The live birth rate without intervention is 10%. The third cause is or third risk factor is genetic. Genetic, we differentiate. We have two: either parental chromosome or embryonic chromosome. paternal chromosome, 2 to 5% of couples with recurrent miscarriage, one of the partner has balanced structural chromosomal anomaly, most commonly balanced reciprocal or Robertsonian translocation. Although these are phenotypically normal, their pregnancies are at increased risk of miscarriage, and this may result in live births with which have multiple congenital anomalies or mental disability. Okay, the risk of miscarriage in this depend on the size and the site of the translocation. The site, this is a genetic content. According to the genetic content of the portion that is translocated, it will affect, it will show in the fetus. Okay, 30 to 57% in couples with recurrent miscarriage, they will have chromosomal abnormalities in the baby or in the embryo, 30 to 57%. So it is the most common cause of miscarriage in general. The most common cause of miscarriage in general is embryonic chromosomal abnormalities. However, it is important to note that, okay, with increasing number of miscarriage, you will have a miscarriage with euploid pregnancy. So a normal fetus will miscarry. This was increased number of miscarriage. Okay, anatomical factors. We have two sides, either the uterus or the cervix. So the uterus, any uterine malformation will lead to a miscarriage, and cervical weakness will lead to miscarriage. Congenital uterine malformation, this is from 1.8 to 37.6. As we said, is the varying range. If you see a wide range of incidence, prevalence, anything like this, you know that there is no wide study, no big study for this. Okay, so some like a center who is a tertiary center that all these cases are transferred to it, and the primary center who just get one or two. So you will find this this difference is according to the studies, every study, the study and the population in this area. Okay. So you will also this line, the second line is you will find in the question box that arcuate uterus miscarry in the second trimester, while septate uteri in the first trimester. The prevalence of uterine malformation higher in the second trimester miscarriage compared to first trimester miscarriage. But both are associated with cervical weakness. Okay, only 50% will have term delivery. Cervical weakness, this occurs in the second trimester. You will this is diagnosed usually by history. Will have a history of second trimester miscarriage preceded by spontaneous rupture of membrane or brainless cervical dilatation. Endocrine. Okay, endocrine. The most important endocrine factor is diabetes. If diabetes diabetes and thyroid disease, but if both are under control, they are not a risk factor. So any patient with diabetes, she has to undergo a hemoglobin A1C level before. This is as antenatal care, you should do it before or preconception and in the first antenatal visits. Once you see her and she has a history of diabetes, or at least history of gestational diabetes, you have to do hemoglobin A1C to know if her sugar level was she maintained it for the past months or no. Okay, BCO. Okay, maybe linked, but the exact mechanism they don't know. Elevated free androgen index. This is a prognostic factor for subsequent miscarriage. This is with a BCO. Okay, with BCO, you should measure free androgen index, and this will be your indicator for subsequent miscarriage. Okay, infective agents, they don't cause recurrent miscarriage, because for any agent to cause recurrent miscarriage, it must be capable of persisting in the genital tract and avoiding detection. It must cause insufficient symptom to disturb a woman, and I don't think any infection can meet this criteria. So they no longer support torch screening, and the only thing that we need to address is the vaginal bacterial vaginosis. It has to be treated in the first trimester because it is linked to second trimester miscarriage and preterm delivery. It is treated with oral clindamycin, and this is enough to reduce the risk. Inherited thrombophilic defects. This is most important in the second trimester miscarriage. Any type of inherited thrombophilic defects like activated protein 3, deficiency of protein C and protein S, antithrombin 3, hyperhomocystinemia, prothrombin gene mutation. Any of this can cause miscarriage. Okay, carrier of factor 5 Leiden and prothrombin gene mutation, these have double the risk of experiencing recurrent miscarriage compared with women without these thrombophilic mutations. Any woman comes to you with a miscarriage in the second trimester, single. You don't have to wait for 3 consecutive. Single miscarriage in the second trimester. This is an indication for thrombophilia screen. Investigation for antiphospholipid. We have to measure antiphospholipid antibodies. This is routine for all cases. We have to measure it and remeasure again. At least 12 weeks apart. 12 weeks after the initial treatment, if the initial screening, if it is positive. Okay. Karyotyping. Karyotyping of product of the third conception must be underwent. Okay, and that couples with balanced translocation, they have a low risk of 0.8% of pregnancies with an unbalanced karyotyping surviving to the second trimester, and their chance of having a healthy baby is 83%. Balanced translocations we can find in 1.9% of parents with recurrent miscarriage. This is the prevalence of the condition. Anatomical factors, we should do pelvic ultrasound to assess uterine anomaly. If uterine anomaly is suspected, we could undergo hysteroscopy, laparoscopy, 3D ultrasound, whatever the method you are available for you. Thrombophilia, as I said, this is any woman with second trimester miscarriage, even one second trimester miscarriage must be screened for thrombophilias. Treatment, antiphospholipid, it is treated with low-dose aspirin and heparin. and this decrease miscarriage rate by 54%. Which heparin to use? Unfractionated low molecular, they have the same effect, but low molecular weight heparin has a less side effect, less heparin-induced thrombocytopenia, less heparin-induced osteoporosis. While unfractionated heparin, no, it will have more side effects like heparin, like I said, bleeding, hypersensitivity, heparin-induced thrombocytopenia, osteopenia, and vertebral fracture. Corticosteroid or IV immunoglobulins, they have no rule here, so don't use. Complications. When you give the patient low dose aspirin and heparin, she still have a risk. She's still a high risk for complication during all 3 trimesters, like miscarriage, like preeclampsia, fetal growth restriction, and preterm. So you should assess her risk for all these genetic factors. Genetic factors, abnormal parental karyotyping. We should refer for clinical geneticists. Their future reproductive options include they can proceed to having a future new natural pregnancy, or with or without prenatal diagnosis test, or they can go for gamete donation or adoption. They have 50 to 70% chance of healthy live birth in the future, just without treatment, just going with natural birth or natural pregnancy. While they have approximately 30% chance if they opt for IVF and pre-implantation genetic diagnosis. So their chance with natural pregnancy is very, very good, and they should be encouraged to go with this option. Pre-implantation genetic screening with IVF fertilization or IVF treatment. In patient with unexplained recurrent miscarriage, this don't improve the live birth rate, so don't do it. It is just it will cost too much, and it is of no use. Anatomical factors, congenital uterine malformation. There is a debate whether to remove the septum or not to remove the septum, so it is insufficient evidence. So you can do either, if you can either do it or not do it. It is according to cervical weakness and cervical circulation. Cervical circulation only to women who are likely to benefit. So, who are likely to benefit? Those are when we measure by ultrasound, we will find that cervical length is 25 millimeter or less before 24 weeks of gestation. If you find this, okay, she is a good candidate for cervical circulation. Transvaginal is a method of choice, but if the patient has a previous failed transvaginal, or she has very short scarred cervix, you should go for transabdominal. Endocrine factors. Insufficient evidence that progesterone, HCG, or metformin supplementation will affect the outcome. Also LH suppression in patients who are ovulating, who have PCO and they are ovulating, also it don't improve the live birth rate. So no endocrine intervention is required. Immunotherapy. I didn't explain the immunology factor because frankly I don't understand it. For me it is just gibberish. I don't understand what he is saying. The only thing that the CD count, the complement, there is something wrong in the complement and the antigen presenting cells that it is attacking the pregnancy and so on. So just it never came, and I don't think they will ever bring it up in an exam because we have a major things that can be treated. We cannot focus on something that we have no power upon. Okay, and also in the treatment, maternal cell immunization, third-party donor leukocyte, trophoblast membrane, intravenous immunoglobulin in women with previous unexplained recurrence does not improve. So we have no control over this situation. So I don't think logically it cannot come in the exam. Inherited thrombophilia. There is insufficient evidence to treat these cases with heparin, to treat if you treat it with heparin, there is insufficient evidence that this will change the outcome. It may improve the live birth rate but as I said, there is insufficient evidence. Unexplained recurrent miscarriage, don't do anything. If she has unexplained recurrent miscarriage, okay, keep trying, and give her a support. Refer her to a support group, refer her to community-based support, anything, but don't give her medication. She has no problem. Don't give her medication. She has a future successful pregnancy. Future successful pregnancy rates for this patient are 75%. So don't give only with support. So don't give her anything, just emotional support. Okay, this is we are finished. Thanks God. This is the explanation. All explanation finished. Now we will go back to the questions. Finished. Okay. We will start from the beginning. Share. Okay. So this is the first question. It is an EMQ, like you see. This one is from BUS MRCOG website. The first 12 questions are, and the remaining are from Andrew, the new version 2019. Okay. First thing I want to tell you: never read the answers before you read the questions. Treat EMQ as SPO. Just read the question. Get an answer or two in your mind and search for them in the options. Okay, this is the best way to solve EMQs. Okay, you are with me, guys? I think you are asleep. Who are with me?
I follow you.
Okay. Okay. So first question: 26 years old is referred to the recurrent miscarriage clinic along with her 27 years old partner following a third consecutive miscarriage. The following results are noted. Maternal antiphospholipid antibodies and thrombophilia screen negative. Cytogenic analysis on the product of conception reveal no chromosomal abnormalities. Pelvic ultrasound normal. What is the most appropriate next investigation or treatment? First, what is this? How do you diagnose this case, Dr. Izdihar? She's not. Anyone, you can write in the in the comments. You can write in the chat if you cannot speak. You can write in the chat and I'll see what you wrote. Okay. So for me, from what I see, this patient have nothing. She has unexplained recurrent miscarriage. So we will not do anything. We will just offer her support. Okay. Let's see. Let's go back and see the options. Here are the options. Corticosteroid, no. Metformin, no. LH suppression, all HCG supplementation, one A, B, C, D, A, B, C, D, all are not an option. So you just go ahead and cross them because we don't use any of these in miscarriage. Aspirin plus heparin, no, she is not antiphospholipid. Refer for uterine septum resection, no, she have no uterine abnormalities. Refer to genetist, why? She has no, karyotyping is normal. Referral for IVF, no. Supportive care, so the answer will be E, supportive care. You go like this for these questions. Okay, so it is supportive care. The next question, 33 years old, is referred to the recurrent miscarriage clinic along with her 31 years old partner following third consecutive miscarriage. The following results are noted. Maternal lupus anticoagulant detected on 2 tests taken 14 weeks apart. We said that 2 positive tests 12 weeks apart. So this is antiphospholipid. Thrombophilia negative, cytogenic analysis, no chromosomal abnormalities, pelvic ultrasound normal. So this is a case of antiphospholipid treated with aspirin and heparin. Okay, so here we will treat with aspirin plus heparin. Okay, 29 years old is referred to the recurrent miscarriage clinic along with her 29-year-old partner following third consecutive miscarriage. The following results: maternal antiphospholipid and thrombophilia negative. Cytogenic analysis on product of conception revealed an unbalanced structural chromosomal abnormality. Pelvic ultrasound is normal. So this patient, we have to know if the parents have it or no. So before we refer to a genesis, we have to do parental karyotyping as well. So parental peripheral blood karyotyping is the choice here. Okay, very easy. Someone? Anyone? Dr. Sarah, can you speak? Okay, what percentage of women are affected with recurrent miscarriage? We said this. No. Okay. 2%. 2%, and I told you 1 to 2%, and it is, I told you when I said it, it is very important. 35 years old woman is seen as pregnancy booking. She is concerned about her age and the effect on the pregnancy. What would you advise her regarding her risk of miscarriage on her age? She is 35. I told you it is 11, 13, 11, 12, 15, 25. Yes, Dr. Umar Hassan, it's 25. It is 25%. Okay, so this is the next. You are investigating a couple for recurrent miscarriage and have discussed possible causes, including antiphospholipid syndrome. Which of the following statement regarding diagnosis of antiphospholipid syndrome is true? We said before, to diagnose antiphospholipid syndrome, we should have two positive reading 12 weeks apart. So the answer is definitely D. 32 years old patient who was seen at 9 weeks gestation with threatened miscarriage is seen back in clinic for a follow-up scan and advised her current pregnancy has miscarried. This is her third miscarriage, so she has recurrent miscarriage. The previous pregnancy miscarried at 7 weeks and 9 weeks, respectively. What is the appropriate management from the list below? What investigation we do for recurrent miscarriage? Here he is guiding you.
No. Maternal.
Okay, look.
E.
No, also no. He is. This is what I was saying. He is guiding you to say, okay, she is miscarrying now. She has certain miscarriage. Okay, we have a product of conception. We can karyotype. No, this is we have to have basic investigation. The basic investigation for any case of recurrent miscarriage is maternal antiphospholipid antibody screen, pelvic ultrasound, and the product of conception. E. E.
Yes.
Yeah, the answer is E. All of them we have to do. Okay, so keep this in mind. For any case, you will see he is guiding you somewhere. No, he is just trying to confuse you. No, this is just she haven't done any workup yet, so we have to do all the tests. Okay, patient seen in the clinic following 3 consecutive first trimester miscarriage. All investigations are normal. What is the risk for further miscarriage based on the miscarriage history? After 3 consecutive miscarriage, what is the percentage of patient will have another miscarriage? We said
40.
Yes, exactly. This is 40%. We said this before. Okay. Okay, a couple are seen in clinic for follow-up due to 3 consecutive first trimester miscarriage. The product of conception karyotype report suggested unbalanced structure chromosomal abnormality. What is the most appropriate management? How you will manage this? We had a product of conception. Yes, doctor is the heart. Yes, paternal peripheral blood karyotyping of both partners. This is what we have to do. After, if one of the if the same question and he told you that they had parental peripheral blood karyotyping, and one of the parents has chromosomal abnormality, then we will refer to a genetic counselor. Okay? A patient is being seen in your clinic following a third consecutive first trimester miscarriage. Bloods have shown the presence of antiphospholipid antibodies. You have advised the patient to take aspirin and heparin in her next pregnancy. She is reluctant to take medication and asks what are the chances of successful pregnancy without medication. Successful pregnancy without medication with antiphospholipid. We said this also. Yes, exactly, Dr. Istihar. It is 10%. 10% will have this. Okay, it's clear. Years old nulliparous attend the clinic following her first miscarriage at 18 weeks. This is second trimesteric miscarriage. Which of the following should be part of the management plan? No.
C.
C? No. Not C, not E. This is a second trimesteric miscarriage. For all, I told you before, for all second trimesteric miscarriage, we have to do thrombophilia study. Baba? Wait a minute. ايه بدري كده ليه؟
مفيش تعبان شوية.
ألف سلامة في ايه؟ ده انت تعبان خالص. أجيب لك عصير ولا أعمل لك شاي؟ عايز عصير من اللي هو